Good evening and namaste everyone. It is our great pleasure to welcome you for today's webinar on Meet the Expert on latest treatment updates. We are truly honored to host such a distinct faculty this evening. Tonight's session will focus on some of the most significant advancement in the treatment of EGFR mutant non-small cell lung cancer, with a particular emphasis on real-world evidence and clinical experience with osimertinib. Thank you for joining us, and we wish you an engaging and insightful evening ahead. Without any further delay, I would like to invite our first speaker, Dr. Abhishek Bansal, to begin evening session. Sir is a consultant medical oncologist, Suraj Prakash Hospital, ESI Hospital, ESI Medical College, Faridabad, and Bansal Hospital, Palwal. He will give his talk on osimertinib real-world evidence as a first-line therapy. It's over to you, sir.
Thank you for the kind introduction. Can you put on the slides, please?
Yes, sir.
So, good evening, everyone. So, my topic for today's evening is osimertinib real-world evidence as first-line therapy in metastatic non-small cell lung cancer. Next slide, please. So, coming to the FLORA study, which was the basis for this uh, drug, osimertinib. So, coming to the study, patients with locally advanced or metastatic non-small cell lung cancer with key inclusion criteria included more than 18 years, WHO performance status of 0 to 1, exon 19 deletion, or relative 58R, no prior systemic anti-cancer or EGFR TKI therapy, and stable CNS metastases were allowed and were stratified by mutation status by exon 19 deletion or LAT58R or race, Asian or non-Asian, and they were given osimertinib versus the EGFR TKI competitor like the gefitinib or the erlotinib. And RACIS 1.1 assessment was done every 6 weeks, and primary endpoint was PFS, and secondary endpoint was overall survival. And basically, uh, following the crossover was allowed for patient in the EGFR TKI competitor arm who could receive open-label osimertinib upon central confirmation of uh, T790M positivity. Uh, Next slide, please. So this is the baseline characteristics of the study. You can see they were stratified by sex, age, race, smoking status, CNS metastasis, WHO performance status, and overall disease classification, histology, and the EGFR mutation at randomization. Next slide, please. So this is coming to the Kaplan-Meier curve. You can see the median PFS of osimertinib is 18.9 months versus the comparator arm that is only 10.2, and the hazard ratio 0.46 with the curves separating. So suggesting favorable the osimertinib. And also coming to the forest plot in which all the subgroups, as we discussed in the previous slide, the it is shifted to the left, which favors the osimertinib, suggesting the benefit of osimertinib in all the settings compared to the EGFR TKI. Next slide, please. So coming to the final overall survival analysis, median overall survival was 38.6 months in the osimertinib group and 31.8 months in the comparator group, and hazard ratio was 0.8, suggesting the benefit of osimertinib also in the OS setting. and you can see the Kaplan-Meier curve as it is separating, and also in the forest plot, it is favors the osimertinib arm, and mainly it is shifted towards the left. Only some part is crossing the midline, suggesting the benefit of the osimertinib even in the overall survival. Next slide, please. So basically, the FLORA CNS analysis, osimertinib demonstrated improvement in CNS PFS versus EGFR TKI comparator. And you can see there is early separation of curves, basically, and the median CNS PFS was not reached in osimertinib arm versus the comparative TKI, which is 13.9 months, hazard ratio of 0.48, and it demonstrated a clinically significant and meaningful improvement in CNS PFS over EGFR TKI competitors in the first line treatment of patients with CNS mets from EGFR metastatic non-small cell lung cancer with a 52% reduction in the risk of CNS progression. Next slide, please. So coming to the FLORA CNS analysis, cumulative incidence of CNS progression, you can see the probability of experiencing a CNS progression event in the absence of non-CNS progression or death was consistently lower with osimertinib treatment compared with the EGFR TKI. As you can see, the osimertinib, the CNS progression is low as compared to the EGFR TKI. Next slide, please. So coming to the safety summary, there was not much serious side effects, and it was safety profile was consistent to the previous EGFR TKI despite a longer duration of exposure. Next slide, please. So coming to the FLORA conclusion, osimertinib resulted in a significant improvement in PFS over EGFR TKI, hazard ratio of 0.46. Also increased duration of response. Median duration was 17.2 months versus 8.5 months. The osimertinib demonstrated a statistically significant and clinically meaningful improvement in OS. Median OS in the osimertinib arm was extended by 6.8 months, 38.6 months versus 31.8 months. Hazard ratio was 0.8, and osimertinib demonstrated a nominally statistically significant clinical meaning improvement in CNS PFS versus the EGFR TKI comparator, and the safety profile of osimertinib was similar to the EGFR TKI despite prolonged exposure. Next slide, please. So coming to the questions unanswered as FLORA trial, what we know is that there was excellent OS and PFS was achieved. Median age group was 64. Osimertinib demonstrated improvement in CNS PFS. But what the unanswered questions? Will this be replicated in real world? Will it be tolerable in elderly? Will this be replicated in real world? Next slide, please. So coming to the real world studies, provide data from patients who represent the real world population, including patients with specific subpopulation. You can see the randomized control trial and the real world evidence. So randomized control trial is wide unequal acceptance, but acceptance is high. But in the random real world evidence, adoption not pervasive. I think we can go ahead with the real world evidences. Next slide, please. Now coming to the real world evidence studies, the various for the osimertinib. Next slide, please. Coming to the first study, the FLOWER, the real-world prospective observational study enrolling patients referred to 9 Italian oncology centers, OCI FACT, retrospective multi-center cohort study, which is Japanese Mykonos Global Observational Cohort Study, analysis of registries and an electronic health records, Spanish study, retrospective multi-center study, HOT 2002 study, observation, retrospective, non-interventional, local, multi-center study in elderly. Next slide, please. The PFS in real world, the defined time to treatment discontinuation defined as a date of starting a medication to the date of treatment discontinuation or death, a more suitable endpoint to evaluate treatment outcomes in pragmatic real-world trials on TKI. Time to treatment period, time from receiving the first dose of osimertinib to the date of last uh, administration. Time to next treatment or death defined as time from a next death until the start of next systemic therapy or death. PFS has been maintained in real-world studies. Next slide, please. Coming to the PFS in real world, the flora, the flower, cause effect, Spanish study, Mincos, and the Hot 202. This is the median PFS. In the flora, as we know, 18.9, but in flower, it was 18.9, was effect 20.5, Spanish study 25.9. In the Minoco study 16.2 and Hot 2002, 19.4 PFS has been maintained in real world studies. Next slide, please. So flower first line osimertinib in the real world and integral prospective study. It was a real world prospective observational study. Italy, 9 centers. It included June 18 to September 20, first line metastatic advanced EGFR positive non-small cell lung cancer, stage 3B or 4, and baseline EGFR status was exon 19 positive mainly, and then exon 21, and median age was 68 years, adenocarcinoma was 120, squamous cell was 3 only, PS greater than 2 was only 12.7%, and brain mets at baseline was 30.2. And you can see that the patients, the PFS, uh, basically, median PFS in patients with or without brain mets at diagnosis, and also with and without symptoms at diagnosis, the osimertinib is the clear winner, and the curves are separating the Kaplan-Meier curves. And the median PFS is 13.3 in patients with or without brain mets at uh, diagnosis, and median PFS in patients with and without symptoms at diagnosis is 15.5. Next slide, please. So most common side effects as expected from EGFR TKI was diarrhea, skin rash, and paronychia. No difference in survival outcome was observed according to age, morbidity, and type of EGFR mutation. Osimertinib confirmed effectiveness and safety in the real world as seen. Next slide, please. Coming to the next study, OSIFACT, osimertinib as first-line treatment for advanced EGFR mutation non-small cell lung cancer in real-world setting. Here also it was done as a retrospective multi-center cohort study done in Japan, August 18 to 2019, and first-line metastatic advanced EGFR mutated non-small cell lung cancer. Median age of patients was 71 years. Adenocarcinoma constituted the major, and squamous cell being uncommon like 4, and brain mets at baseline was 31%, and it was also PDL1 TPS was followed and stratified in the criteria. And you can see PFS after first line in osimertinib treatment in real world practice was favorable. And next slide, please. So basically, median time from onset of treatment to onset of adverse effects was 56 days, and grade 3 events basically comprised of pneumonitis or QT interval prolongation, and reasons for treatment discontinuation included disease progression or pneumonitis or other adverse events and progression of other diseases. Next slide, please. Minocos is the real-world study of patients with EGFR mutated, locally advanced or metastatic non-small cell lung cancer treated with first-line osimertinib. Was a global observational study, USA, Japan, Germany, and China, April 2018 to March 2021. First-line osimertinib metastatic advanced stage 3B or 4 EGFR mutated non-small cell lung cancer and PS greater than 2 was only 14.2%, mainly adeno-CA 97.4%, sum of being squamous cell that is 1.3%, median age was 70 years, brain mets at baseline were 33.6% based on the first data cut analysis of the US population. First line osimertinib therapy patients remained 58%, 18% received second line treatment, and the interim results support the effectiveness of the osimertinib in the real world population. Real world time to treatment discontinuation was 17.2 months and real world to next treatment months. Next slide, please. Minoco's interim analysis of a real world patient registry in Germany based on the first data cut analysis of the German subpopulation. The interim it could be seen that the results PFS was 16.2 time to treatment discontinuation was 19.2 months and time to next treatment or death was 14.2 months. So listing the benefit of osimertinib. Next slide, please. So coming to the Spanish study, first line osimertinib real world evidence study design include the eligibility criteria of EGFR mutation non-small cell lung cancer, presence of exon 19 or ALAT58R mutation treated with first line osimertinib therapy between January 2013 and June 2021. Data collected and analyzed in endpoints was PFS and OS. Next slide, please. So you can see the median PFS was 25.9 months and the curve being separated, and overall survival was not reached in the osimertinib when we did a follow-up, and the confirms the efficacy of osimertinib as standard first-line treatment in real-world clinical patients with advanced EGFR mutated non-small cell lung cancer, suggesting benefit in both PFS and OS. Next slide, please. So will the benefit be seen in elderly? This was a retrospective observation study. It was done in Japan. Multi-institutional median age of the patients who were included was 80 years. And you can see that the median PFS of 19.4 months in the elderly was seen, and median OS was not reached. So osimertinib was the one of the first effective first-line therapeutic options for patients 75 years or older. Next slide, please. So will the benefit be seen in elderly? We did a meta-analysis of EGFR TKI randomized controlled trials in older adult patients with advanced EGFR mutated non-small cell lung cancer. The study concluded the osimertinib achieved a higher PFS than all other TKIs did. Osimertinib is the preferred EGFR TKI for treatment of older adult patients uh, with advanced EGFR mutated non-small cell lung cancer. So how will the benefit be with the CNS Mets? You can see in the FLORA there was CNS PFS was maintained in the osimertinib arm. It was not reached versus 13.9 months, and secondary also there was benefit in the secondary endpoints. And FLORA China study incident CNS progression was lower in the patient receiving osimertinib than on those receiving comparative EGFR TKI. PFS benefit with osimertinib was consistent in patients with and without CNS Mets at baseline, being hazard ratio 0.6 the with Mets and 0.51 in without Mets. Osimertinib in first line EGFR mutated non-small cell lung cancer. This is head-to-head TKI clinical trials in advanced non-small cell lung cancer EGFR mutated median PFS results you can see, and the osimertinib in this the FLORA trial the highest PFS which is 18.9 months, and compare a second generation being the dacometinib which is 14.7 months versus the first which third generation which was 10.9 months. And basically CNS Mets was the only FLORA was the only trial which included the CNS Mets. Otherwise, all CNS Mets were excluded, and also symptomatic brain Mets were excluded from all the trials. Next slide, please. So, how will the benefit be with CNS Mets? Osimertinib for EGFR mutant lung cancer with CNS Mets, a meta-analysis of EGFR TKI's osimertinib efficacy on patients with CNF Mets and EGFR mutated non-small cell lung cancer. Overall response rate was 71%. Median PFS was 12.21 months. And you can see, next slide, please. So this is coming to the NCCN guidelines for exon 19 deletion or the EGFR exon 21 mutations, with the preferred being osimertinib as the NCCN guidelines. Next slide, please. So to summarize, real-world analysis studies help in evaluating efficacy of osimertinib in patients who are usually excluded uh, from randomized controlled trials. Osimertinib has demonstrated benefit in the real world, which is constant with the results seen in the original FLORA trial. Current real world evidence study shows osimertinib in the basically efficacy in the old age group, and also the presence of brain mets or any ethnicity or specific mutation types. More real world evidence studies are anticipated covering various population types, which in turn would give deeper insight about the osimertinib potency in a large scale. Next slide, please. I think my talk is finished. Thank you. Thank you everyone for patient listening. Any questions, please, and I'm happy to answer.
Thank you, Dr. Abhishek, sir. There is any question? If no question, we will move forward. For the next talk, I would like to invite Dr. Prashant Kumar. Sir is a medical oncologist at HCG Cancer Center, Cuttack. Sir will give his talk on real-world evidence osimertinib in treatment in EGFRM NSCLC. It's over to you, sir.
Thank you very much. Good evening, everyone. My slides are visible?
Yes, sir, visible.
My topic is real world evidence osimertinib as standard of care in the management of EGFR mutation non-small cell lung carcinoma. So in patients with EGFR mutation, PFS improves after treatment with the EGFR TKI compared with the cytotoxic chemotherapy. And as we have already had in FLORA trial, the median PFS improvement is almost 9 months versus first generation TKI, and the median OS improvement almost 6.5 months versus the first generation TKI in the final analysis of FLORA trial. So this is the final analysis already discussed. Osimertinib versus first generation TKI. And crossover was allowed for patients in the comparator EGFR TKI who could receive open label osimertinib upon central confirmation or progression of the disease. So this is the baseline characteristic, and PFS improvement, significant improvement in the PFS, 18.9 months versus 10.2 months, and almost every subgroup has got benefit with osimertinib. And this is the OS data, 38.6 months versus 31.18 months. It's significant. And conclusion from the FLORA trial, it shows statistical significant and clinical meaningful improvement in OS, almost 6.8 months improvement. And the osimertinib is the first EGFR monotherapy to show a statistical significant OS versus EGFR first generation TKI. And after 3 years, almost 28% of patients in the osimertinib and 9% of patients in the comparator EGFR TKI remained in the first line. So the final OS analysis for a trial reinforces osimertinib as the standard of care first line treatment for EGFR mutation non-small cell lung carcinoma. And same thing has been recommended by NCCN. It is the preferred option for EGFR mutation advanced non-small cell lung carcinoma. Now coming to the real world evidences, and all these 3 trials has been discussed. So I'll discuss on some minor aspects, especially the endpoints on all these three trials. The POWER study, first line osimertinib patients with EGFR mutant advanced non-small cell lung carcinoma. It has been estimated that only 2 to 4% of patients with cancer receive treatment within the randomized control trial, thus raising the issue of the representativeness. So, though for any clinical or randomized phase 3 trials, the inclusion criteria is very strict. So, for the real world representativeness, it's less common. Only 2 to 4% are the real world patient reference in clinical trial. So that is a difficulty we can explore in this trial. And the real world data useful to assess the unique insights in routine oncology practice in post-marketing setting also. So these are the key features. In the POWER study, median age 68. So elderly patients has been taken the brain metastasis. As in FORA trial, the active brain metastasis was excluded, but in this POWER study, real world study, almost 30% has brain metastasis. And performance status only 0 to 1. Most of the trials include very good performance status, that is ECOG PS 0 1, but here almost 13% patient has ECOG PS 2 or more. This is the inclusion criteria of POWER study, more than 8 years. Histology is confirmed non-small cell lung carcinoma, presence of EGFR mutation, locally advanced or recurrent metastatic disease, and eligible to the receive first line treatment with the third generation TKI like osimertinib. Exclusion of patients who received the study drug in clinical trials. And these are the primary endpoints. AMTTD, time to discontinuation measured from the osimertinib start to discontinuation therapy for any cause, rate of treatment-related adverse effect, rate of dose reduction, and temporary or definitive treatment interruption. And most importantly, this TTD, time to discontinuous, is under exploration as a pragmatic real-world endpoint because we as a clinician in our clinical practice, so we continue the same therapy, especially when a patient has been on treatment with a targeted therapy. On oligo progression, we usually continue the treatment, and that is based upon the principle of oncogenic addiction. So in that scenario, this TTD is a very important endpoint. And the other secondary endpoints like median OS, median PFS, overall response rate, disease control rate, progression pattern to osimertinib, and some diagnostic therapeutic pathways. So the patients with poor performance status, comorbidity, rare EGFR mutation, uncommon EGFR mutation, and active brain metastasis were excluded in the landmark FORA trial. So outcomes are similar to published data in this POWER study, thus adding consistency to osimertinib efficacy. And there is no difference in PFS, time to discontinuation, and overall survival were noted in the elderly patients, where most of the elderly patients were excluded, patients with comorbidity and less common EGFR or uncommon EGFR mutations. So primary assessment, median time to treatment discontinuation. So time to treatment discontinuation, median was 25.3 months, which is even better than the FORA trial. Median time to treatment discontinuation patient with or without symptom and diagnosis. So no symptoms, the median time to discontinuation not reached versus those who are having symptoms, it is 18.8 months. Similarly, those having patient with less than 3 or more than 3. If less than 3 months, the median time to discontinuous not reached versus 21.4 months, those having more than 3 metastasis. That means oligometastasis or less than 3 metastasis, they does better. So there was no difference in PFS, TTD, OS, and this TTD we have already discussed appears to be more suitable endpoint to evaluate treatment outcomes in the pragmatic real world trial, and the TTD was longer, that is 25.3 months than the post-progression outcome analysis FORA, that is only 20.8 months. Probably this due to study population unfit for further therapy or different therapy for oligoprogressive disease. And better time to discontinue is associated with fewer than 3 progression sites. That means less than 3 metastases and isolated progression, oligoprogression compared to the oligo or systemic progression. So this is the few characteristic like symptom or diagnosis. If a symptom is absent, then there is a significant improvement. And similarly, for site of metastasis less than 3, there was a significant improvement, better than more than 3. Brain metastasis present and absent. If absent, then there is significant benefit. So at median follow-up for 12.3 months, median PFS was 18.9 months, and median was not reached at the time of data cutoff. That was 18% censored, CR 0%, partial response in 73%, stable disease 23%, and progression disease only 4%. So the progression-free survival median was 18.9 months, and median PFS in patients with or without brain metastasis diagnosis. If there was no brain mets, then PFS not reached. Versus if brain metastasis, then PFS is 13.3 months. Similarly, to patient with or without symptoms, if no symptoms, PFS not reached versus 15.5 months if PFS is. So the PFS analysis after median follow-up, the 18.9 months median PFS and median age was not reached at the time of data cutoff. PR was 73%, again, stable is 20%, progression 4%. So on the multivariate analysis of these endpoints, longer PFS was noted in the absence of brain metastasis. That is not reached for the 13.3, and prolonged PFS not reached for 15.5 months, and longer OS also noticed in patients without symptom, and time to discontinuation at 9 months or higher was significantly associated with better overall survival. So the real world diagnostic features essential element of evidence-based medicine and would help in clinician decision making. So among patients experiencing progressive, that means 44 patients had progression, out of which 21 cases underwent a rebiopsy, and out of the 21 cases, 14 cases undergo tissue and 6 liquid biopsy, and molecular analysis performed in all these 13 samples, and the druggable resistance mechanism seen in MET amplification was more common in 4%, MET and EGFR both in 1, EGFR in 1, or 2 amplification in 1 patient. Safety data, ILD pneumonitis, as we know, is a common side effects with osimertinib, and it is seen in 9.5%, but most of them are grade 2, grade 1 or grade 2. Similarly, diarrhea, stomatitis, rash, dry skin, paronychia, all of them are commonly seen in TKIs. So, and most of them are grade 1 or grade 2. One toxic adverse event, that is venous thromboembolism, seen in 9.5%, and almost the grade 3, grade 4 venous thromboembolism is seen in almost 8%. So 110 patients experience adverse events, 33% grade 3, grade 4. Venous thromboembolism is the most common, seen in 7.9%, and in the real world asterisk study, grade 3 pulmonary embolism accounted for 2% of treated patients treating osimertinib, and there is no difference in rates of VT was reported according to the age, performance status, comorbidity, and tumor load. So same thing in tabular form, there was univariate p-value not significant. So no difference in survival outcomes observed according to age, comorbidity, type of EGFR mutation, and also confirmed effectiveness and safety in the real. Now coming to the osifact, osimertinib as first line. This is another real world study. The current study investigated the difference in the efficacy and patient background and safety of first line osimertinib in the real world scenario. Inclusion criteria: advanced EGFR positive non-small cell lung carcinoma, osimertinib as the initial treatment, and patients concurrently using other anti-cancer agent or undergoing thoracic radiotherapy, undergoing post-operative adjuvant chemotherapy, receiving osimertinib as second line. These are excluded from the study. Baseline characteristic: age median 71 years, slightly elderly population, male 34, female 65. The echo performance 2 11%, 3 4%. So some of the poor performance status patients they have taken. and never smoker 61. So the primary endpoint was PFS, secondary endpoint OS, and trying to treatment failure, response rate, safety assessment, and among the response rate, CR, PR, stable disease, progressive disease, objective respiration, and DCR. So these are the secondary endpoints. PFS events occurred in 182 of 538 patients, so median PFS 20.5 months. So other parameters significantly associated with PFS. Male gender, there was significantly associated with less PFS less than the significant malignant diffusion, liver metastasis, and advanced unresectable cases. We know liver metastasis, malignant plasma associated with poor prognosis, so they has been associated with poor PFS. And with respect to PDL1, so this PDL1 status, because we know patients having PDL1 high patients, even EGFR mutant positive, we should start anti-EGFR TKI. So median PFS was not in patient with TPS less than 1%, and 14.7 months if TPS less than 49, 11.1 months if TPS more than 50%, and not in patient with other. That means if PDL1 level is higher, then PFS is less. So same thing, you can see male gender, malignant diffusion, liver metastasis, advanced stage, and higher PDL status associated with less PFS. So reason for treatment discontinuation, almost 44.3%. They discontinued due to disease progression, 25.6% due to pneumonitis, 16% due to other adverse effects like anorexia, skin disorders, cardiac failure, QT prolongation, fatigue, anemia, thrombocytopenia, hematological disorders, GI bleeding. So due to almost 60% of other adverse effects and 14% due to did not follow patient request or doctors. So adverse effects, safety profile, pneumonitis, all grades 12.8%, and grade 3 or less 4.5%, grade 5 4%, hematological toxicity 4.3%, QT interval prolongation 4.1%, and all adverse events leading to treatment discontinuous almost 17% of patients in this study. The conclusion from the study, overall response rate was 76.2% and disease control at 94.1%. PFS is better with osimertinib than conventional EGFR TKI, and that is irrespective of PD-L1 expression. Median TTF was 19.1 months. The median time from start of treatment to the onset of adverse was 56 days. Pneumonitis, all grades occurs in 12.8%, though grade 3 or higher in 4.5%. Fatal pneumonitis in only 4 patients. So conclusion from these studies, PFS after first line of treatment, real-world practice was favorable, and discontinuation rate is due to adverse effects 18%, especially pneumonitis require further investigations. So the real-world study patients with EGFR mutated locally advanced background of this study, osimertinib is the third generation irreversible TKI. We have already discussed about the data about the FORWARD trial, but this study reports the demography and clinical characteristics of real-world time to next treatment discontinuation, and real-world time to next treatment and death, and real-world time to discontinuation of patients with advanced EGFR mutant positive non-small cell lung carcinoma who are on first line osimertinib. This is a global observational prospective code study ongoing in USA, Europe, and Asia, and involves analysis of registry, electronic health record, data from country-specific data. This USA sub-analysis include data from the National Flatiron Health Electronic Health Record de-identified database. During the study period, the de-identified data originated from the approximately 280 US cancer clinics, almost 800 sites of care. For this interim survey, data were collected to the June 2030 to 2020, and the study is ongoing. Follow-up period is planned until June 33, and patient, this is the inclusion criteria. More than 18 years of age, advanced non-small cell carcinoma, stage 3 or stage 4, EGFR mutation documented prior to the start of therapy, and initiated the first line osimertinib. So this is the index date initiated for first line osimertinib. baseline clinical and demographic characteristics and treatment pattern summarized during descriptive statistics. KM analysis are used to generate the estimates of TTNTD and TTD. The real world time to next treatment and death was defined as time from an index date until the start of the next systemic therapy or death in the option of next systemic therapy. Whereas RWTTD, that is real world time to discontinuous, is time from index date until the earliest end date of associated with the discontinuation prior to the end of the first time. So this is the patient characteristic. EGFR mutation positive, the total number of patients 558, exon 19 280, L858R 185, and exon 819 deletion plus both 4%, both common and uncommon mutation in 22%, uncommon mutation 52, unknown mutation in 5 patients. So at the interim analysis, the treatment sequencing 318 patients, then almost 58% remain on first line osimertinib therapy or were lost to follow, and 18.18%, 103% received second line treatment, including anti-PD-1, PD-L1 mono or combination therapy, EGFR TKI, monotherapy or combination therapy, patient-based chemotherapy, and 101% died while on first line treatment. So this is the first line osimertinib 548, second line 103 received, died while in first line 101, discontinued first line 26, remained on first line therapy or lost to follows 318 patients. So the real world time to next treatment and death, median follow-up time was 9.6 months. Median real world time to next treatment or death was 17.9 months. 204 events occurred and 101 patient died, 103 patients switched to second line therapy. In the multilateral, these are the following variables are significantly associated with the real world time to next treatment or death. Age at initial diagnosis, smoking status, Charlson comorbidity index more than 3, EGFR mutation type, number of metastatic sites. The same thing has been depicted here in the first plot. And the median real world time to discontinuation was 17.2 months, 230 events occurred, 101% died, 103 switched to second line, 26% discontinued. So in the variables in the multiple analysis, following variables are significantly associated with the real world TTD, Charlson comorbidity index more than 3, performance status more than 2, EGFR mutation type, number of metastatic more than 4, or evidence of liver metastasis. So take home message from this study. The study provides real world insights into the use of first-line osimertinib in patients with advanced EGFR mutation non-small cell lung carcinoma based on the past data cut-off analysis on US population, the interim real-world time to next treatment and death, and real-world time to discontinue results support the effectiveness of osimertinib in this real-world population, and longer-term outcomes will be evaluated in final analysis. Thank you for patience hearing. Any questions?
Thank you, Dr. Prashant, sir. We will wait for 2 minutes. Dr. Ganesh will join us within 2 minutes for the next talk. Dr. Sushmita ma'am, can we start from you? Dr. Ganesh have some urgent work. He will join within 5 minutes.
Hello, am I audible?
Yes, ma'am. Yes, ma'am, you are audible. For the next talk, I would like to invite Dr. Susmita Sadhukan, ma'am. She is a medical oncologist at Tata Medical Center, Newtown, Kolkata. She will give her talk on reimagining CNS mutation in EGFR metastatic advanced lung cancer, how treatment compare. It's over to you, ma'am.
Very good evening. I hope my screen is visible and I'm audible.
Yes, ma'am. Screen is
So,
visible and you are also audible.
yeah. Okay. Thank you. Thank you for the opportunity. In the next 10 to 15 minutes, I will discuss reimagining CNS mutation in the EGFR mutated advanced lung cancer and how are the treatments right now. So, first of all, coming to the incidence, I will know that non-small cell lung carcinoma is the most commonest one. Accounts for around 85% of the lung carcinoma, whereas only 15% comprises of small cell lung carcinoma. Among the NSCLC, although the most common mutation is KRAS, the most common actionable mutation is EGFR mutation, is overall accounting for the around 17% of the mutation, whereas the rest of other common mutation like ALK, RAGE mutation, or ROS1 mutation, all are below 5%. So EGFR mutation is the most commonest actionable mutation in NACLC. And there is a quite very geographical variation worldwide in the EGFR mutation prevalence, starting from 15% in the different parts of the Europe to it is highest in the Asian countries, and it is around 60. It can go as high as 60% around the Asia in Asia. So now coming to the brain metastasis, as we all know, that brain metastasis is pretty common with lung carcinoma, and such incidences are more pronounced in EGFR mutated patients. So, in a study at final follow-up, there was 44% of the patients with EGFR mutated tumors had brain metastasis compared to the only 22% of the patients who had wild-type EGFR. However, among these brain mets, leptomeningeal metastasis has compared to worse prognosis compared to others, and when not treated, is only the survival is around only 4 to 6 weeks. So, leptomeningeal metastasis may be more frequent in patients with EGFR mutated. If we compare, it is around 9.4% in the mutated subgroup versus only 1.7% in the wild type subgroup. So approximately 10 to 20% of the NSCLC patients have brain metastasis at the time of diagnosis, and approximately 40% will develop brain metastasis during the course of the disease. So if we compare the site of metastasis and quality of life of the patient, it can be seen the patient with even a single brain mets experience greatest decline in quality of life compared to a site of the metastasis. So now the role of TKI in brain metastasis in EGFR mutated CLC. The brain is a sanctuary site for invading metastatic tumor cells as it is protected by the blood-brain barrier. Up to 40% of the patients with non-small cell lung cancer with EGFR mutations will develop brain metastasis eventually. EGFR hello.
Yes, ma'am, you are audible.
Hello.
Yes, ma'am, you are audible.
Yeah. Sorry for the technical glitches. My network is not stable. So I
No
hope this.
problem.
So the AGR for human blood-brain transporters to varying tissues, and this influences the distribution of hormones in the brain. Since it is impacted, the EGFR TK must have a good brain penetration if they are to achieve a healthy concentration. So also penetrates the inter-blood-brain barrier in monkeys in states. Osimertinib also demonstrated higher mouse brain concentration than compared to other TKIs. The study showed on animals showed that osimertinib has the highest penetration compared to the other first or second generation TKIs. So osimertinib causes tumor depletion in EGFR mutated brain metastasis in the mouse xenograft model. So all preclinical studies showed a good intracranial activity of osimertinib. So it also distributed in all regions of the brain in healthy volunteers. It is also proven. And also achieves brain exposure in patients with EGFR mutated advanced initiated brain metastasis. It is showing regional distribution of on paid parametric images. So in nutshell, osimertinib binds irreversibly clinically relevant mutant EGFR kinase form, that is the most common 858 mutation, exon 19 deletion mutation, and also as well as the T790M mutated EGFR domain. To selectively make the EGFR kinase activity, it has shown to prolong the PFS and OS relative to the first generation EGFR TKI. It has also exhibited anti-tumor effects in patients with NSCLC harboring various EGFR mutations, common as well as the uncommon mutations. It is a high blood-brain barrier penetrance and brain exposure to other EGFR active in the CNS metastasis. It also inhibited growth of CNS mets with EGFR mutation positive NSCLC. How does the efficacy of osimertinib compare to the first generation? We all are aware of the plot, which has shown the compared to the first generation EGFR TKA. The patient was all EGFR metastatic NSCLC untreated, and it was tested. Osimertinib was tested the first time compared to the other comparatively EGFR TKA was the first generation and primary endpoint was PFS. The majority of the patient had median is around 18.9 months in osimertinib group, and in the comparative arm, it was only 10 months. And if we see the overall response rate is around 80% with the osimertinib with 76%, and median OS was also improved. It is 38.6 months compared to the 31.8 months.
Ma'am, your slide is not
So
visible.
if you can see,
Ma'am, please make your video off. We will present your slide. It will help you in network issue.
yeah, just share the video PPT you can.
Ma'am, please make.
Hello, am I audible?
Yes, ma'am, you are audible. Please make your video off. It will help you in network issue.
Sorry, sorry.
Ma'am, please make your video off.
Hello.
It will help you in network issue.
Okay, sure. Is it visible now, the screen?
Yes, ma'am. Screen is visible now.
Okay, sure. So, if we analyze the CNS result, so the left half is showing the no not treated CNS metastasis, and the right half is showing without no not treated CNS metastasis. In both the subgroup, osimertinib showed a PFS benefit. In the known cases also, the osimertinib showed a median PFS of 15.2 months with the standard of care where it is 9.6 months, and with a hazard ratio of 0.47. And in the also without known or treated CNS metastasis, also osimertinib is 19 months showing a median PFS, and with compared to the 10.9 months with the first generation TKI. So CNS progression events occurred in 6% of the osimertinib treated patient compared to the 15% of the patient receiving osimertinib. So in FLORA trial, osimertinib demonstrated a superior systemic PFS benefit regardless of the CNS disease state at the study entry. So if we consider the CNS full analysis, the median CNS PFS was not reached compared to the 13.9 months with the first generation TKI, and CNS overall response rate is around 66% compared to the 43%. So osimertinib has significantly longer OS than comparator EGFR TKI. At 24 months, 70% of the patient compared to the only 60% of the patient, and at 36 months, 54% in the osimertinib compared to the 44% of the first generation TKI were aligned. So again, this is the already discussed the CNS pool analysis state that the median CNS PFS was not reached osimertinib arm compared to the 13.9 months. So CNS PFS was statistically significant with the use of osimertinib compared to the first generation TKI. So CNS progression, if we consider the CNS progression, it was shown in the occurred in the 20% on the osimertinib arm, whereas it was 40% and 40%, so it is almost double in the comparator arm. So no only treat, but it also prevent the occurrence of the CNS, new CNS metastasis, and also progression of the existing CNS disease, also prevent the progression of the existing CNS disease. So in the this trial, which included patient with and without CNS metastasis, the investigator assessed CNS progression events were observed in 6% of the osimertinib arm compared to the 16% in the comparator arm. So if we consider the use of next line of systemic therapy, osimertinib also delayed the use of second line therapy. So if we see the osimertinib versus the first generation, so first line, if you use the osimertinib as the first line drug, it also may delay the need for subsequent therapy. 28% of the osimertinib patient versus 9% of the first generation TKI patient was continuing to receive the first line trial even at 36 months. So this is now some case studies and real world evidence on the osimertinib, which those patients also had a CNS metastasis. So rapid intracranial response to osimertinib without radiotherapy in non-small cell lung cancer patient harboring the EGFR T790M mutation. So case 1, so this was 67-year-old woman who underwent right middle lobe resection of the lung because of the early stage NSCLC 9 years ago. However, multiple nodules emerged eventually in both lungs in image 7-year-old, which was recognized as a recurrent, and patient was having EGFR mutation or EGFR L858R mutation, and patient was started on gefitinib as a first-line chemotherapy for 2 years and 11 months after 3 lines of cytotoxic drug regimen, that is carboplatin plus pemetrexed, tegafar, gemenacel, and notarisil plus bevacizumab. Orlotinib was administered as fifth-line chemotherapy and also as EGFR TKI re-challenge option, which failed in next 3.5 months. So after 2 courses of again vinorelbine administration as 6th line of chemotherapy, the patient complained of unbreakable back pain, and it showed MRI showed a spinal exam detected multiple thoracolumbar bone mets. So bronchoscopy had been was conducted as a biopsy measure, and it detected an mutation in the T790M in the exon 20. And as a 7-line therapy, osimertinib 80 mg per day was administered. From the next day, brain nodules were detected. On day 5 after administration of osimertinib was started, HS X-ray revealed shrinkage of the right pulmonary nodule, and CT images on day 13 revealed complete remission of the brain mets except for the one lesion in the left frontal lobe. So this is the summary only. So patient was started on osimertinib after so many lines of chemotherapy as well as the first generation TKI or were all exhausted, and patient was having a T798 mutation, and as a later line option osimertinib was started finally, and patient responded symptomatically as well as the image on imaging as well. So this is the multiple brain metastasis at the baseline, and the image is also showing the chest X-ray. There is shrinkage of the pulmonary nodule even only after 5 days of osimertinib administrations. So this is the case 2. A 76-year-old man with a heavy smoking history underwent right upper lobe resection of the lung because of the early stage NSCLC 10 years ago. Patient was having EGFR exon 19 deletion mutation. Patient had a multiple bone metastasis as a recurrence, which occurred 6.5 years ago. And Gepitinib was administered again as a first line for and patient had it for 4.5 years. Then Afatinib was administered for 10 months after sandwiching 4 courses of carboplatin plus pemetrexed with bevacizumab. So while fourth line chemotherapy, that is Tegafar, Gimenacel, and Notricel was being administered, pleural effusion with right-sided dominance was seen. A thoracocentesis was conducted and detected the pleural fluid detected T790M mutation, and osimertinib was administered at the fifth line chemotherapy, and the patient performance status was ECOG grade 2. So on day 10 after administration of osimertinib, brain CT images revealed the remission of single brain mets in the right parietal lobe, which was asymptomatic. And on day 14, there was decrease in the pleural effusion and shrinkage of pulmonary nodules were recognized apparently on a chest X-ray. After rebound, chest CT images revealed shrinkage of multiple lung mets and decrease of the left-sided pleural effusion. Gradually, his performance status improved to ECOG 1, and there is also decreased pleural effusion as well. So this is the imaging showing the response, complete remission of the brain nodules, single brain mets. So this is the case 3. There is a complete remission of the multiple brain mets in a patient with EGFR mutated NSCLC treated with first line osimertinib even without the help of brain radiotherapy. So a 74-year-old patient who had no smoking history, and patient had a elevated blood CA level. The CT scan revealed a 40 mm shadow in the upper lobe of the left lung and multiple bilateral small nodules in entire lung field. Patient was diagnosed with the T4N1 and M1, that is stage 4B lung adenocarcinoma, and with a EGFR exon 19 del mutation positive. So more than 20 multiple asymptomatic brain mets with a maximum diameter of 12 mm were detected in brain MRI. Patient was started rightfully for osimertinib for the on first line 80 mg once daily, and however, as the whole brain palliative RT was deferred. So this is the there is multiple bilateral lung nodules, small nodules throughout the entire lung field, and patient was also having multiple small brain mets, almost more than 20. And after 5 weeks, the multiple brain metastasis has disappeared completely. So this is the lower half is the imaging after 5 weeks, and there is, according to the imaging, there is complete response after 5 weeks of osimertinib. So intracranial outcomes of de novo brain metastasis treated with osimertinib alone in patient with newly diagnosed EGFR mutant NSCLC. So it's a retrospective cohort study, and patient was selected from an institutional database. And patient was selected if they had a diagnosis of EGFR mutant NSCLC and treated with osimertinib between the year 2014 and 2022. Although it received osimertinib alone as the initial therapy after first brain mets diagnosis, had at least one intact brain mets not previously treated with systemic or local therapy at osimertinib initiation, and had a baseline brain MRI before and at least one scan after osimertinib initiation. This is the patient characteristics, and we can see there was a significant patient. 36% of the patient had a more than 11 brain metastasis. So this is the baseline pre-osimertinib scan. This is the regression of the disease 2 months of post-osimertinib scan, and this is the 34 months of post-osimertinib. So disease control in this, they showed a disease control was seen until 34 months of post-osimertinib. So there are 36 patients who had a median interval from brain mets diagnosis to first line osimertinib initiation of 25 days. In total, 136 previously untreated brain metastases were tracked from baseline. Overall, 77% had a complete response and 31 patients had a partial response compared to the baseline MRI images. This reflects a best objective response rate of around 100%, and there was 2-year overall survival of 80%. CNS progression rate at 1, 2, and 3 years of post-osimertinib were around 20%, 30%, and 40% respectively. So lesion level local failure was estimated to be 0.7%, 4.7% at 1 and 2 years post-osimertinib respectively. So what are the recent guidelines updates suggest? So even the NCCN, this is NCCN version 1 2024 data, they are also the category 1. If the patient is diagnosed with the most common EGFR mutation, whether it's a EGFR exon 19 or exon 21 mutation, so patient is advised to start on the third generation TKI, that is osimertinib upfront, or if the patient is having a good performance status and having a CNS disease, so we can combine the TKI with the platinum combination agent. So if the patient is having a good performance status and that disease bulk is huge, disease bulk is there, patient is symptomatic, we can combine the osimertinib along with the pemetrexed or carboplatin, pemetrexed plus carboplatin as well. So we have to continue if we are combining with the chemotherapy, usually go for the 4 cycles of platinum doublet chemotherapy plus osimertinib, followed by a response assessment scan. And if the scan is showing a good response, at least a stable disease, we will continue the osimertinib plus pemetrexed maintenance till disease progression or unacceptable side effect. So thank you for your patience listening. If you have any questions, I'm happy to answer that. Thank you.
Thank you, ma'am, for your wonderful talk. For the last session of the day, I would like to invite Dr. Ganesh Chandra Subodhi, sir. He is a consultant medical oncology at Apollo Cancer Center, Bhubaneswar. He will give his talk on exceptional response to osimertinib, EGFRM, metastatic NSCLC. It's over to you, sir.
Please share the slide from your side.
Okay, sir. So you can start now.
Yes. Hi, namaste to all. I'll talk about osimertinib. Before starting the response to osimertinib, I'll share my personal experience. My recent patients with osimertinib, 2 patients actually not did well. One with the brain mets and other was not brain mets. After 2 months of osimertinib also, the patient symptomatic breathlessness was not going. So started chemotherapy, but subsequently patient respond to some time. Then again I have started afatinib, responded for some time but didn't do. And second person with brain mets didn't do also. After 2 to 3 we have been given patient was symptomatic brain mets. In that case we have given osimertinib. And RT also given, we have started RT, but 2 to 3 weeks only patient could have survived. So the heterogeneity lies in the metastatic CA lung. There is a lot of work to be done, but yes, some patients do well. Let's talk about how this patient did well. Next slide, please. Here is a case, 64-year-old gentleman, coughing, presented with cough, progressive breathlessness, and severe backache. He could not walk without support in last 10 days. Giddiness since 5 to 6 days. Weight loss 5 kilo. Personality non-smoker. Here you can see the patient is looks like a symptomatic brain mets. Next slide, please. Here you can see that right Apollo mass 4.1 into 3.2 and multiple bone mets are there. Next slide, please. Biopsy came out to adeno and TTF1 positive, napsin A positive, negative for P40. Mutation analysis came out to exon 19 mutation and KRAS, BRAF, MET, ALK, ROS, and PD-L1 negative. Next slide, please. Here you can see large brain mets and both sides are there are brain mets. Next slide. Cerebellum and cerebral hemisphere with significant perolesional vasogenic edema is present. Next slide, please. Stage 4 definitely with exon 19 deletion with bone and brain mets. Management definitely if the patient is symptomatic, definitely we offer we consult our radiation oncologist and as per and we consult them and if there is possibility of SBRT or SRT, then we consider tell them to do that. And nowadays whoever WATRT as osimertinib has brain penetration and we see many cases excellent response. So in this case, like my previous case, symptomatic brain mets, I have started with radiation. Then I started osimertinib. Next slide, please. Here you can see that how the PFS benefit from first generation to third generation. Definitely osimertinib stand out. Next slide, please. Osimertinib's brain concentration definitely is higher. 2.78 compared to Gefitinib 0.17, Apatinib very less. And brain plasma Cmax ratio 3.4 on osimertinib. Definitely with the symptomatic brain mets or asymptomatic brain mets, we consider third generation osimertinib. Next slide, please. Here you can see homogeneous the distribution of osimertinib. Next. Regional distribution, you can see that definitely when the dose passes, that like I said that my first patient, the with brain, my recent patient with brain mets died within 2 weeks. Definitely, patient should allow around 3 to 4 weeks to have a good response to that. Till then, the supportive care and overall clinical care of the patient is very much needed. Until that time, radiation and steroid may take the roles. Next slide, please. Here you can see how we can flow chart. We have how we can progress with EGFR positive non-small cell. If brain mets is symptomatic, definitely we consider local therapy as patient attendance also worry, and definitely we try to give a good quality of life so that patient take care about to him and patient attendant take care about them patient. And if no symptom asymptomatic, even though multiple brain mets, we can start osimertinib. And till that time, if there is some mild edema, we can give steroid and anti-epileptic drugs. And if progression of fast and secretion EGFR TKI and if symptomatic, uh, 1 second. If symptomatic, then we will consider if CNS progression or other systemic progression. If CNS progression T790 mutation is there, then we will consider osimertinib. And if T790 mutation negative, we can give SRS, continue TKI. Even actually, if the CNS is when patient is asymptomatic, we can continue TKI. But definitely, if we should consider also the other factors, systemic how it is controlled, and we should also discussion about the option of osimertinib. And now, even though osimertinib's cost is down, still the cost is out of reach for most of the patient in the India. So we can consider a second generation TKI at least. If you patient is asymptomatic and CNS and systemic PD, then definitely we can, if T790 mutation is present, then definitely we can consider osimertinib. And negative SRS, or WTRT or chemotherapy, all we should consider all the factors and affordability, and we should also reserve the TKI as after osimertinib the next molecule is not there, and the other new drug abimantanab and other drugs, definitely they are also costly. So judiciously you should use the TKIs. Next slide, please. Here you can see FLORA trial with the brain outcomes. If you non-treated CNS mets and without CNS mets, treated CNS mets, both say you can see that the Kaplan-Meier curve separate early, and hazard ratio both side is very good, 0.47 and 0.46, and PFS if treated patient 15.2 versus 9.6 around 6 months, and if not without treated, definitely stands around 8 months. Next slide, please. FLORA trial and brain outcomes, afatinib, dacotinib, and osimertinib. Definitely osimertinib stands out, and afatinib, dacotinib don't consider they do well. But definitely, if you EGFR mutation is there, some form of TKI we give the patient, and patient may have benefit. But definitely, if brain mets is there, then we should consider osimertinib. As you can see that 15.2 versus 9.6 PFS benefit is there. Next slide, please. Treatment for bone mets palliative radiotherapy spine for Becker, Zolendanic acid, you can consider denosumab. For brain mets, patient did not to take brain RT and wanted to see later, started on fast line TKIs. Next slide, please. Follow PET CT, March 21, right Apollo, NKC, right Apollo bronchus, size reduced drastically. Right hilar and parietal also node drastically. Significant there is response. Next slide, please. Here you can see that the efficacy of osimertinib fast generation TKI compared to fast generation TKI, CNS overall objective response and duration of response, disease control rate, and the CNS duration of response, all are greater compared to fast and second generation, fast generation TKIs. Next slide, please. Here you can see that all the brain mets resolved completely. Next slide, please. Complete resolution we can see, no additional intervention is needed. Next slide, please. One case report, second case we'll discuss. One case of that was upfront metastatic brain mets. Now we'll discuss the stage 3 relapse with brain mets. Subsequent and reveal medicinal notes. Repeat brain found to multiple brain mets. 3.1 inferior to Vermeer metastasis. Osimertinib was started, but after osimertinib started, patient complained ataxia. Patient can become symptomatic. So craniotomy and tumor excision following was done. Next slide, please. So here you can see that here we can see that if you give osimertinib to different brain mets, one of the case multiple brain mets, and a patient is asymptomatic, osimertinib did well to one of the patient and did not require any radiation therapy. Next slide, please. And phase 2 trial, open label 3 on prospective. Here given the osimertinib both treated naive patient, either treated naive patient or previous treated with EGFR TKI or T790 mutation. All 3 cases osimertinib did well. Intracranial objective response, intracranial disease control rate, and intracranial progression free survival. Either T7/9 mutation is there, patient treated with TKI or not, definitely osimertinib standard out. So if there is asymptomatic brain mets also, we can give osimertinib, and if the symptoms are mild also, we can consider. But if symptoms are so severe and affect the quality of life, we consider radiation. Otherwise, as if we can see, consider around 3 weeks, if the patient can allow us, definitely we can consider osimertinib. Next slide, please. Here you can see that almost complete response is there. Next slide, please. Radiotherapy brain non-needed still patient had complete resolution of brain mets, almost complete resolution of primary disease nodes. No adverse events were reported in this patient. Patient remained progression for after around 19 months, which did well as per osimertinib. He is asymptomatic and fully active and did his normal works. Next slide, please. Acceleration osimertinib are such tumors different? Do we have biomarker to predict acceleration? Definitely, here both cases did well, but recently my two patients didn't well. Although my previous experience with osimertinib was good, but osimertinib also have thromboembolism in one of my patients. One should also consider. And second is that we should not consider biosimilar osimertinib. Definitely, we should take the from AstraZeneca, and we should also watchful to patient how patient is doing. Not that all patients will will respond to osimertinib. There should be a newer molecule and effective molecule and cost effective molecule, and there should be also biomarkers. So how which patient will respond to osimertinib, which will not osimertinib. There is lot of work to be done, and the osimertinib is a hope, and I consider I also think that the cost of osimertinib should also come down, so that our patient will get the benefit. Still now the cost is too much high for many of the patient. So all these are my experiences, and now the session is end from my side. Excellent, please.
Thank you, sir. Thank you all for joining us this evening for an insightful session on the latest treatment updates. A special thank to our speakers for sharing their valuable knowledge. We appreciate your time and participation. Thank you once again. Good night. Thank you.
Thank you. Good night.
Technical team, please close the meeting.